Alrighty, thank you for joining us for our educational webinar, What Causes Trigger Finger and How It's Treated. Tonight's speaker is Dr. James Cassandra, orthopedic surgeon at OrthoNeuro. Dr. Cassandra is a board certified and fellowship trained orthopedic surgeon specializing in hand and upper extremity conditions, as well as general orthopedics, fracture care, and trauma. He has been in practice for over 20 years. Dr. Cassandra will answer questions following his presentation. Please type your questions into the Q&A below at the bottom of your screen. Dr. Cassandra, take it away.
All right. Yeah, thanks for coming. I appreciate it. I have a quick presentation. I had slides, but computer snafu prevented those from coming up. But we'll still go over the topic. It's a great topic. It's very relevant. We see a lot of trigger digits, and it's a condition that's common, and patients we see every day with this problem. So it's a problem that it's gratifying to treat. There's great treatment options, and the trigger digit, something that we'll talk more about tonight. So the bottom line, trigger finger is a painful condition. It's a condition that affects the hand, and it's based on the anatomy. And the bottom line, the anatomy of the hand and forearm, all the muscles in the forearm run down, form tendons, and come the tendons and run into the hand and to the end of the digits. So those tendons, to function properly have to go through a tunnel or a tight space. And that tunnel acts to restrain the tendons and allows you to make full motion with your hand and prevents bow strain. If we didn't have a pulley system, the tendons, you could bend your fingers, but you wouldn't have complete motion. So having this anatomical system, it works well until it doesn't, or until there's some type of pathology or inflammation. And what we see, or call it stenosing tenosynovitis. And that's where there's inflammation around the flexor tendons. And when that happens, the tendon doesn't run smoothly through the tunnel, and there's some swelling and nodule can form, and that tendon gets stuck. And that's essentially what a trigger finger is. That finger gets stuck in a usually flexed position, gets stuck down, the patient can't open it up, and they have to usually use their other hand to snap it open, and it's painful. The causes, this can happen for different reasons. Why this happens in orthopedics, there's many things that we know, but with the human body, it's still a great mystery, and the exact cause is unknown. But we know that there's associated conditions that affect the hand and can lead to a trigger digit, such as repetition and using the hand over and over in a strenuous manner, such as the weekend warrior that decides to paint their house, or a factory worker, or someone who knits continuously. Those are, common things that sometimes can lead to some irritation about that tendon. So strenuous, repetitive motion is one, associated condition. There are other medical conditions that can be associated with the trigger digit. Most commonly, diabetes, especially if the sugars aren't well controlled. That can lead to a condition where there's more tenosynovitis in the tendon sheath. And if that happens, there's a higher risk for that tendon just to get caught up and stuck. Other medical conditions are gout, rheumatoid arthritis, can be classic for inflammation around the tenosynovium and the tendons. The age group is usually between 40 and 60, where the acquired trigger digit can form or present. And it can happen in an older age group, younger, occasionally, not as common, but most commonly if there is someone with poorly controlled rheumatoid arthritis, which isn't as common nowadays, or more commonly diabetes that's heavy on their hand, it can lead to this trigger digit. So what happens is the pathophysiology, there's this pulley system that we talked about. The tendon should be nice and smooth and go through the pulley. That tendon enlarges and gets thicker and the lining of it gets thicker, which we call it tenosynovium. And then the pulley sheath itself, that also gets thicker. And when those two things happen, it causes, number one, more friction. Number two, there's more pressure. And number three, more fluid that forms in the tendon sheath. That tendon sheath is a confined compartment, and there's only so much space. So that confined compartment fills up, and it's hard for that finger to move. So that painful condition develops and the finger starts to trigger. The good news about this, when coming in to see the doctor or hand surgeon, this is an easy diagnosis compared to some things that we have to diagnose or work up. I think two things are key. Number one, we need a good history from the patient. Oftentimes if you listen to the patient, you can deduce what's going on. So number one, good history. And then number two, good physical exam to examine the trigger digit. There are other conditions that can mimic trigger finger. So it's important to make sure other conditions aren't going on. Sometimes the medical staff thinks it's a trigger digit, but it could be the other side of the hand's affected, where the sagittal band ruptured and then the extensor tendon triggers or catches, and it can present and look a little bit like a trigger digit, but the cause is totally different. There could be a Dupuytren's, which causes a contracture of the joint from an injury, or a tendon injury. All those conditions or all those medical diseases can present and sometimes make trigger finger a little more tricky to diagnose. But if you take time with the patient with their history and a physical exam, it can diagnose trigger digit or trigger finger 100% of the time. So the pain that we look, the symptoms we look for, number one, pain at the A1 pulley or usually the palm. There can be swelling in that region of the hand. Sometimes you feel a nodule that can develop. Then as the finger moves, you can see it stick sometimes, it gets locked, then they have to unlock it, or that's what we call triggering, where we have to unlock it or release that lock position. And then if it keeps locking, it can lead to a finger that has decreased motion or it becomes stiff. So the problem is if there's a trigger digit that goes on too long, it can lead to wear and tear on the tendon, where it frays and can tear, or more commonly, the finger can become stiff and a contracture can develop if the patient's not moving their finger through full range of motion. So the treatments, when patients come to the office, it's nice to diagnose what it is, but the more important issue and factor is getting these conditions treated and resolution to the pain and suffering. So first step, ice, anti-inflammatories, massage, all can help on the hand. If those aren't helping, then we often talk about the next step. And the next step is cortisone injection. This can be done in the office. Small injections placed right into the palm, right in this area. Whichever finger's affected, we shoot it, put the medicine in, and it goes down the tendon sheath. And that allows for that anti-inflammatory effect of the cortisone to take place. It causes that inflammation to go down, and the trigger digit can oftentimes resolve. Therapy can be helpful, and some patients come in using splints. I think they may be beneficial at night. It won't usually resolve it, but it might help at night to keep the hand in a more comfortable position and avoid waking up with the finger locked and very painful. And then when a patient comes in, most times the injection can cure this. So I tell healthy patients that 80% of the time the trigger digit can be cured from the cortisone injection. This is done, and within 7 days, it usually gets better. But, for the 20% of patients that it doesn't cure or they don't respond as well to the injection, then the next step is a small surgery. Surgery is an outpatient surgery. It's a quick procedure. It's a gratifying procedure because we do this procedure under what we call MAC local, where the patients in a light twilight, the patients do not have to be intubated or put to sleep, and then we numb up the hand, and then we free up the tendon, and oftentimes we can instruct the patient to move their hand, and we can see that motion and correct itself in the lack of triggering. And so right away it's gratifying. The outcomes are good. It's a quick surgery, takes around 10-15 minutes. Patients go home. Healing times around 10 to 14 days until the sutures come out. With all surgeries, though, there are risks, and the risk, even though it's an easy, minor procedure, the risk we still have to keep in the back of our minds and take seriously. I think the biggest complication that could happen is infection. So keeping that hand protected after surgery, clean, avoiding any contamination is crucial. Having patients optimized for surgery, especially if the patient's diabetic, that means keeping the hemoglobin A1C in a nice level, and avoiding any risk like smoking. Smoking makes healing harder, and then protecting the hand. Therapy usually can be started at home, and therapy can help get the motion back and also work out some of the tenderness that can sometimes occur with the scar. So overall, trigger digit is something that can happen, and most times it happens to the ring or long finger. So ring finger most commonly, long finger are common. The thumb's also common. Index and small finger, it definitely can happen at those digits as well. And then the good thing, the diagnosis is easy, straightforward. Treatment, straightforward. Most times improves with, a cortisone injection or conservative care as opposed to surgical intervention. But when surgery is needed, the outcome's excellent and patients do very well. Thank you. And I'd be glad to entertain any questions.
All righty. It looks like we do have a few questions. I'll start with one of the first that we got in. Do I have to have surgery to fix a trigger finger?
I don't think surgery's a must with the trigger digit. I think that a cortisone injection is my preferred first step. But after 2 injections, if that trigger digit doesn't respond, then I think surgery is the next best, next best option. So 2 cortisone injections, and if there's no relief, and then, surgery. Sometimes the one caveat is with diabetic patients, sometimes the cortisone can bump sugar levels up in diabetic patients, and sometimes the chance of full resolution with injection isn't as high. So if there's any loss of motion, stiffness, concerns about sugar levels and bumping that up, and sometimes surgery could be a consideration before 2 injections.
And then how many injection or cortisone injections can I have?
Usually I say 2, but that's not a steadfast rule, and it depends how long relief is. So if I had a patient who they had 1 injection and it helped a little bit, then they had another injection, 6-8 weeks later, and it helped a little bit but came back within 6 weeks, I'd recommend surgery. If someone had an injection, it helped a year, then came back, then they had another injection, it helped 2 years, then it came back. I think that patient, if they wanted to try to avoid surgery, injection could be done. It doesn't mean that it would resolve it forever, but if they, life gets in the way of surgery sometimes, and we understand that. So the injection in that case could be a good option.
And is physical therapy painful for a trigger finger?
I think therapy for a trigger finger progresses quickly, and everyone's different with pain, but for the average patient, I would say compared to some other conditions we treat, it's advances quickly with a lower pain compared to some other things.
And then I have a follow-up question to the cortisone shots question, and that is, does diabetes preclude more than 2 cortisone shots?
It doesn't, but if it doesn't improve, I think, I think surgery would be a good option. So, I try not to set things in stone. Every patient's different with the conditions they're going through and where they're at in life. So we have to talk about the risk and benefits, and so I wouldn't say it precludes it, but it probably would push that patient down more of a surgical route.
And then if my finger is locked, can you get it unlocked?
Yeah, surgery is effective in getting that trigger digit unlocked, and we see that happen right away in the operative suite. The bigger deal, if it's been locked for a long time, sometimes a contracture of the joint can develop. And if that happens, then, even though the tendon's free, the joint still has to be worked out where that tightness can develop through other structures, such as a capsule or tendon component. So if someone leaves, that's why it's important to get these trigger fingers treated and that motion back. Because if that motion isn't full, restricted for, after a month, 2 months, it can lead to these contractures that become more complicated to treat.
And then how effective is therapy to cure the issue at hand?
I think therapy can help it. I wouldn't say it usually cures trigger digit. I would say it's marginally effective in curing it.
Okay.
I think the bigger options are cortisone injection and surgery.
Alrighty. And then how common is trigger digit?
It's very common. As a hand surgeon, we see multiple cases every day.
And then are oval 8 splints worthwhile?
I think they're okay. It gives the finger time to rest. It may help, prevent the finger from getting caught or locked up. But I think splinting can help try to cool it down. It doesn't always resolve it though.
And then will trigger finger come back if I have surgery?
Can trigger finger come back after surgery? It's not common, but it's possible. And there's sometimes conditions when there's a lot of inflammation around the tendons. This is when it's most common. And even though we free up here, the A1 pulley, we call it, and it's down in this region of the palm. So if someone has surgery, that's freed up, but they have a lot of inflammation, I see it every now and then where the tendon can trigger and get caught up at the A3 pulley. And sometimes that has to be addressed. It's not very common, but it's something that we have to watch for.
Already, that was my last. Go ahead.
Yeah, we like to, when we do surgery, our outcome, we like to have it taken care of forever. That's the goal.
When should I see a specialist for trigger finger?
I think as soon as I would give it a week or two, and if it's not getting better, I think that's a good time.
Alrighty, that looks like that was my last question. If there's any further questions, feel free to let them be put in the Q&A box below. Give it a few moments for any lingering questions. Alrighty. Looks like there's no more questions for this evening. Thank you for participating in tonight's webinar. Our next webinar will be on August 4th at 7 p.m. Dr. Mark Kolich, hip and knee surgeon, will be discussing knee pain. Look on our social media pages for additional information to come. Thank you so much, Dr. Cassandra, for presenting tonight, and good night to everyone. Thank you for participating in the webinar.
Thank you. Have a good night.
Good night. Bye-bye.